all. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So the series for the pediatric GIT surgery continues. Dr. Marc A. Levitt is with us once more. Dr. Marc, thank you very much for being here. And what are we going to talk about today?
Well, great to see you again. I think it's time that we should talk about a congenital problem called anorectal malformation, also known as imperforate anus, in which a baby is born with no anal opening, no ability to allow the stool to pass out of the colon and through the anus.
Got it. Thank you very much. So I'm going to share the screen and we'll start. So very quickly, this is drbeen.com. In the description, you would find a beautiful link to Dr. Bean's premium account. So take advantage of that while I have it in there. Then this is the Children's National Hospital where Dr. Marc Levitt is working. This is Dr. Levitt's biography. Recently, Marc Levitt, MD, colorectal and pelvic reconstructive surgeon, joined our Children's National Hospital community to lead a newly highly specialized colorectal surgery program. I want to share a couple of things here. This program will be the first in the mid-Atlantic region to fully integrate surgery, urology, gynecology, and gastroenterology into one cohesive program for children. And then check out Dr. Levitt's biography, more than 10,000 surgeries. So we are actually fortunate to have Dr. Levitt with us. Thank you very much for being with us. I'm going to quickly just go through a couple of slides here. So first of all, this is the presentation. Secondly, before we go there, I wanted to add this. So because we're talking about inorectal malformations, because we're talking about the openings for the anal canal and its abnormalities, this content may be disturbing for some. For medical professionals, for healthcare professionals, for medical students, for nursing students, this is our job. We have to study these things and we have to understand them. And there can be nothing better than having a head of a program teaching us those things. So those who would find this disturbing, please, viewer discretion is advised. You can please skip if you like, and let's start. So I'm sorry, this was the first.
Yes, and great to be with you, and I appreciate that that comment at the beginning. These are obviously sensitive areas of the body, but we as medical professionals need to understand their anatomy and know how to help children born with these problems. And I can tell you as a surgeon, I have met obviously many parents who have a brand new baby who in whom it is discovered that there is a colorectal anatomy problem, and I have yet to meet any that ever conceptualized that that was something that could go wrong with their baby. Many people know about cardiac defects or cystic fibrosis, things like that, but none of them have ever heard that something could go wrong. It's something that is taken for granted. But if the anatomy is not right in the anal area, then we have a problem where the baby cannot pass stool and it's life-threatening. So we need to figure out what to do. And a big part of that is understanding the anatomy that the baby was born with. And based on that anatomy and our determination of where the structures are, that delineates the plan of care. So we have to show you some photos of anatomy and then how to deal with that anatomy if it happens.
Got it. Thank you very much.
The first comment I want to make is that the diagnosis on occasion is made prenatally when the baby is still in utero. Not often. Most babies born with an anorectal problem are born at term. Everyone expects it's going to be a completely normal delivery and newborn, and then there's a discovery of an anal anatomy problem. But on occasion, there is a clue. And the next image shows such a clue. The one, okay, so this is a 22-week fetus who on the standard ultrasound had a dilated structure in the pelvis, that big white structure in the middle. The one in the front actually is normal. There's a white ball in the front. That's the bladder. That's the bladder. The neck structure behind it is abnormal. That should not be there. In fact, that is the gynecologic system filled with urine because the baby has a malformation called a cloaca in which neither the urine or the stool can exit the patient successfully. And therefore, the urine, instead of flowing out, some flows out, but most flows backwards up into the gynecologic system, making for that dilated structure. So the point here is that sometimes these conditions can be diagnosed prenatally. Otherwise, the baby is quite fit and healthy, and we need to now manage this anatomy problem because obviously anatomy in which the bladder, the gynecologic system, and the rectum are in communication is not going to be successful in having that baby survive. Interestingly, for those of you who know a little bit about nature, this cloacal anatomy is what would be expected in a amphibian, in a bird, for example, a turtle, a crocodile. And for those of you who have ever had a bird poop on their car, you might be happy to know that it was both poop and pee mixed together because all birds have a cloaca. But obviously in humans, we would like those structures separated. All babies in development have a cloaca, and then the correct development is those three structures separate by the time the baby is fully developed. And it's the failure of the separation that defines a cloaca. It's extremely rare. It's about 1 in 25,000 births. I'm going to show you more common malformations that don't involve the bladder or the gynecologic system, but I just wanted to tell you that sometimes these can be prenatally diagnosed. So let's go to the next slide. And let's talk about the baby that pops out. And here's a good example of that. So here's what that looks like. And maybe some of you were sort of thinking what it was going to look like when you ultimately saw a photo. And this is a healthy boy, and there's no opening. Where is the poop supposed to come out? There's no anus. And this particular bottom is a little bit on the flat side. There's not a great cleft between the buttock creases. And that's an important associated issue. Now, whether the rectum formed is a key question, but how well did the muscles, the sphincter muscles around that rectum form? And in this particular case, the flatness of the bottom shows that these muscles are not that well formed, and it could have an effect down the road on continence. All right, let's look at the next one. So the next one is a boy also who is making urine, and the urine is stained with meconium. So this must be a connection between the rectum, which did not come to the surface, and the urinary tract in the front, a recto-urethral fistula. And the other three answers are types of recto-urethral fistulas, but we do not know what type until we do further studies. But we certainly know that there's not supposed to be meconium. Meconium is the term for a newborn's poop. It's still called meconium for the first 24 to 48 hours of life, and that is staining the urine. So obviously there is a connection, an abnormal connection between the rectum that is in there somewhere, we need to find it, and the urinary tract in the front. All right, so here are some more pictures. The picture on the left shows, believe it or not, that is some meconium in that little ribbon, but obviously that's not where the meconium ought to flow. The anal opening, where it ought to be, is missing. There's no hole there, but the meconium tracts forward, and that is something called a perineal fistula. The rectum is almost there. It's reached the perineal skin, but in an abnormal location. And the image on the right is a clue that that may be the situation you're dealing with, and that's called a bucket handle anomaly. You can actually pass something underneath that raised bit of skin, and that is associated with a perineal fistula as well. All right, let's carry on. All right, now here you have a boy and a girl, and what do you notice? There appears to be an anal opening. However, it seems very small. It seems to be in the right location, but is way too tiny to allow poop to flow. And this is something called an anal stenosis. Stenosis is the term for a congenitally narrowed area. So this is an anus that is present, but too small. Let's see the next one. All right, this is a very close-up shot. This is a girl. You can see where the anus ought to go, where that exactly, right where that, there's no hole there. But a little bit forward, you can see a tiny little hole. See that? This is also a little bit forward. Right there is the hole. And that is a hole, but not in the right place and too small. So we need to move that to south in the center of the sphincter and make it larger. And this is also a perineal fistula in a female. Let's see the next one. And what do you think of this one? Normal urethra. That's the clitoris, that's the urethra, that's the vagina. There is a hole. The hole is very small, and it seems to be too far anterior. It belongs just behind it right there, and this is also a perineal fistula. We need to make that hole larger and better located within the sphincters. Let's see the next one. Now this is an interesting one. This looks better, but the hole is still a bit small. So it's better centered. You can see the ellipse, which is the center of the sphincter, and this is further back, but still a bit small, also a perineal fistula. If this hole was the right size, we wouldn't need to operate on it. Okay, let's see another one. And this one is pretty close to normal. This hole is the right size. It's a little bit anterior, but it is good enough. No surgery required for this one. It is within the sphinctered ellipse, and it is the right size. We'd have to check that with a measuring device, but I can tell you this one does not need any surgery.
So I have a question for this one. As the person grows, will this distance increase, or this distance would stay proportionally?
Precisely. It will increase, and therefore reaffirming that no further surgery is required.
Got it. Thank you.
Let's see the next one. All right. Now this one, you can see a normal urethra and a vagina, and there's another hole right behind the vagina. Obviously, that does not belong there. It belongs a little further back where there is a sphincter. And this is called a rectovestibular fistula. Vestibular fistula, meaning the hole is in the vestibule, which is the location right behind the vagina. Very common in females to have this. Okay, so the next one is sort of a summary, an artistic diagram of normal female anatomy with a superimposed yellow dot of where the rectum can land. So starting from the left, we have a vestibular fistula location. The next one is a perineal fistula, but pretty close to the vagina. The next one is also a perineal fistula, but a little bit further from the vagina. The next one is a perineal fistula too. It's very small, but it's sort of located well, but quite a little bit anterior. And the final one is in the right location, but too small. So that one is anal stenosis. So those are the versions that you can find. And I can tell you, the doctors and nurses taking care of these patients need to look carefully at this anatomy, which why I've spent so much time discussing it. And based on where the hole is located and based on its size, determines the next step, either no surgery required or a minimal surgery to move the hole, or on occasion, a colostomy bag with a surgery plan for a couple months down the road. Okay, let's see the next one. All right, now this is a patient with no anal opening and a single hole at the area of the normal urethra where the urine would come out. And you can see that in the middle panel. There's no holes here except for one tiny hole where the urethra, where the urine would come out. And this is called a cloaca. This is the image, like the picture I saw in the fetus, the picture in the fetus. And you can imagine when this baby tries to pass urine, it may not efficiently exit the patient, but go backward and fill the gynecologic system. This is a cloaca. This patient needs a colostomy and then a complex reconstruction at about 6 months of age, and then the colostomy can be closed. Okay. Next one. All right, I think it's important to mention that many of these patients do not have a colorectal problem in isolation. They have associated malformations, and the clinicians taking care of these patients in the newborn period need to check for these and find them and deal with them if there are associated malformations. So let's see how to remember that. So that's called Vacterl, Vacterl. Some call it a Vacterl syndrome. And what do those stand for? V, vertebral, A, anal, C, cardiac, T, trachea, E, esophagus, R, renal, kidney, and L, limb. So bones, some bony issues. And that's a good way to remember all the associated things that can go wrong if the anus is also abnormal. And this is the screening studies. Obviously, a physical exam we talked through already, but x-rays of the thorax and abdomen, the sacrum, ultrasound, looking at the kidney, the pelvis, and the spine, and checking out the heart with an echocardiogram are mandatory when you have a brand new baby with no anal opening. Make sure you know if there are other things to be managed.
So, quick question for you. Is this common, highly likely to be these associations, or it's always going to be some more than just that malformation?
Well, the lower the malformation, the more normal the rectum is, the less likely there will be any additional problems. The higher the rectum, the more complex the malformation, the more likely that something associated with that anorectal malformation will be present. We routinely screen all such babies and many times come up with completely normal examinations. But sometimes we have an issue with the kidneys, and then we have to involve the urology team. Sometimes we have an issue with the spine, and we have to involve the neurosurgery team. These are the screening protocol to make sure we know everything about the baby. The obvious thing is the anus is not right, but these other things aren't obvious at first. You need to look for them to make sure nothing needs to be done about those issues.
Got it. So if I become a student for a second, what you're saying is the higher this opening from its original position, the more the higher the likelihood that there would be some more abnormalities as well.
Yes, that's correct. And it's particularly clear if we look at the different malformations in a male, because then you can really see the height of the rectum as it descends into the pelvis. The
Got
female,
it.
you're absolutely correct in what you just described, although for someone they would say the hole is it's reached where it needs to go. But the male is very obvious. The rectum is either high in the pelvis or very, very low in the pelvis. And the higher the rectum ends up, the more likely there is an associated problem.
Got it. So just one more question. My apologies. If the anal opening is just missing altogether, regardless of what its position is there a higher association then with these extra abnormalities?
The answer to that is yes. In males, almost always there's no anal opening. It's hiding somewhere inside. In females, usually you see the anal opening, but it's not in the right location.
Got it. Thank you.
All right. Well, I sort of alluded to this. These are part of the Voctoral syndrome, but we have learned over time that if we know the type of malformation, which is illustrated in the picture on the left, here the yellow is the rectum and the orange is the urinary tract. This is a male. And the rectum doesn't go all the way down like it should. It ends in the urinary tract. So if you know the location of the rectum, if in the middle panel you know the quality of the sacrum, how well did the tailbone develop? Because the tailbone's development is nicely matched to the muscles and the nerve development. So if you have a well-developed sacrum, you have well-developed muscles and nerves. If you have a poor sacrum, you have a poorly developed set of muscles and nerves. And the spine, you have a spine in the far column. Is that normal or abnormal? So if you know these three qualities, you can make a good prediction of the continence. And I can tell you, as soon as the family comes to grip with the fact that their baby has an anorectal problem, their first question is, will the anus that the surgeon makes, will that anus work down the road? Not how important or detailed or what required to make that anus. Of course, those are the things that the surgeon worries about. They want to know, is the anus going to work? And here, if we have these three pieces of data, we can have a very intelligent conversation with the family of whether or not the baby is going to have completely fine continence or is going to struggle. And as I will talk about in the follow-up podcast, the follow-up video lecture to this one, is how do you achieve continence? And if they are not likely to achieve continence, meaning the rectum is very high, the sacrum is poor, there's a problem with the spine, we still, through bowel management techniques, can get the patient clean and in normal underwear, just like the other kids. But it takes a little bit more work in those circumstances.
So I have a question. Um, the absence of the anal opening can give a clue that the anal opening is somewhere else inside. The abnormality with the spinal cord may even be sometimes may be palpable. How do you find out sacral abnormalities? What tests are done?
Yes, I believe I have a nice image of that coming up. Thank you for that lead. There you go. It's almost like we're partners in this educational experience. Nicely done. Here is a diagram of the sacrum, and we have marked off the key bony elements. The top line is the top of the iliac crest. The middle line is the sacroiliac joint, line B, and line C is the tip of the coccyx. And in this case, the top half and the bottom half are equally matched. And that's a normal sacrum. If you took an x-ray of a normal sacrum, it would look like that. In an anorectal malformation patient, the bottom half is foreshortened. It doesn't develop well. So if you think about that, in this case, you'd have a sacral ratio approaching 1. The top half and the bottom half are equally sized. If the bottom half is very short, the sacral ratio, the BC divided by the AB, is a smaller number. And the lower that number, the more problems of continence prediction. So it's a way to grade the development of the sacrum.
Got it.
Okay, let's see what the next slide gives us. Now, this is an image of both an ultrasound on the left and an MRI on the right of what's called a tethered cord. The spine, the end of the spine, is tethered. It's stuck to the sacrum. And when the spine elongates, it stretches that distal end. If on where your cursor is, it's a little whiter. You can see a little strip going up that's white. Go north a little bit, up, 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 up. But no, the middle one. Yes, that white thing is the end of the spine, which is tethered to the very right bone. That is supposed to be free floating. That's called a tethered cord. And it can be associated with both urinary issues and occasionally bowel issues.
So, is that surgically corrected, or you leave it to
Yes.
grow and observe?
Yes, we need a neurosurgeon, and it's actually, I don't think any neurosurgery is straightforward, but according to our neurosurgeons, it's a very straightforward neurosurgical procedure where you go in and clip that so it's no longer stuck to the sacrum.
Got it.
So this is what I refer to as a report card. Essentially, it's the ARM continence predictor. And if we know the type of malformation, the quality of the spine, and the quality of the sacrum, we can come up with a score, and we can help the family be guided by the likelihood of continence down the road. We are currently studying these scores across hundreds of patients through a consortium, the PCPLC, if you want to look that up, Pediatric Colorectal Pelvic Learning Consortium, PCPLC. It's a group of institutions that have decided to work together. Very lovely group of about 20 or so programs, and we are studying this to validate this score. But it's a very good way of talking to families at the moment, but very soon I believe we're going to have really accurate numbers that if your score is a 7, your likelihood of continence is 95%, things like that. Okay.
Got it.
All right, now we're going to take a couple slides to talk about what needs to be done surgically to the newborn. What do we do? Do we either do a colostomy, which is a colostomy bag? I'll show you some pictures of that. Or can we do a primary repair? Can we fix the anus right then and there in the newborn period and send the baby home with a normal anal opening so they can have normal poop without any further surgery than that? So let's go through a couple examples of that. So this is a baby. I showed you something similar with a perineal fistula. No opening, but almost an opening. Where the white is mucus, and it's trying to break forth. Yes, and it belongs there. This is a baby we can do a primary anoplasty on. We can find the rectum. It's right below the surface and make an anoplasty right there, and the baby can eat and poop and has a very good chance of having normal bowel control in the future. Sometimes we can take this picture, which is the baby from a cross table lateral, also called crossfire. And I don't know if you can notice this, but you can see the air column. The one on the top is pretty obvious. The air column almost gets to the skin. Look how close it gets to that white probe, which is to mark the skin. All you need to do is bridge that little gap. And that's certainly one that could be done in the newborn period as an anoplasty without needing a beginning colostomy. And this is a baby with no anal opening at all. So we asked,
And this is true that the baby was born today,
yes,
or
no,
it is
no.
uh,
It's
if the baby
this
is born today.
Yes, this is a theoretical. When I talk to my trainees, I say, imagine you had this baby that was born today. What would you do? And they
Got it.
know, or they should know, that you don't rush to operate on such a baby. You give the baby about 24 hours to declare themselves. Where will the meconium flow? Will it flow to the anal area through a fistula? If so, the baby could have an anoplasty in the newborn period. Will it flow into the urinary tract like the picture I showed you before? The baby might have stained urine. Then they need a colostomy. But nothing to do today. But we have to decide what to do tomorrow.
Got it.
All right. And this is a baby with a vestibular fistula. We talked about that. This one's particularly interesting because there are a couple ways to manage it. You could do a newborn repair. The anus is right there. You could gently dilate that hole, let the baby poop, not in the ideal location, but it's just going into a diaper, so there's no urgency, and do a repair in about 3 months. Or you could do a colostomy, then the repair, then the colostomy closure. And I would base this on the experience level of the surgeon. And also, if this is discovered in the newborn period, you really have a good option to do a newborn repair. But as you could imagine, if this baby doesn't get a careful exam, again, this is why we're spending such time on the exam. This baby might be discharged home pooping into their diaper. No one would know until they looked. And if the baby gets to 6 months of age, that's not the ideal time to do a primary repair. So such a baby probably ought to get a colostomy and a delayed repair. But if you look at the perineal anatomy carefully, and all babies who are born should have this exam, you won't miss something like this.
So I have a question. The presence of the opening here and passing of the poop here, wouldn't that contaminate this remaining area and cause infections or
It's a good
issues?
theoretical question, but not really. The poop flows out and does not go back in.
Got it.
All right, and this is an image of a baby who just underwent a colostomy. We have brought the colon to the surface. That's the belly button there. And off to the patient's left is a red blob. That's the colon. And the diagram shows what that looks like from the inside. And the poop now comes to the abdomen into a bag. And the fact that there's no anal opening downstream is not really relevant for the baby. They poop, they can eat, they can go home, and they can come back another day for their anal reconstruction.
Got it.
All right, let's talk a little bit about radiology and planning for the surgery. So now we have a colostomy, and we're doing a special x-ray through that colostomy. And the image on the left lights up the rectum, but with a little more pressure, the image on the right now shows the true anatomy. And now you see that the rectum is actually quite low, but interestingly, it fistulizes, it connects to the urinary tract in the front. And you can see at the very bottom of the rectum, you go to the bottom of the rectum, there it is, there's the fistula. It goes and flows into the urine in the front. So follow, there you go, that's the bladder. And then the other line going down is the urethra. Go down to the left, to the right now. There you go. That's right. That's the urethra. So you can imagine this baby might pee with a meconium stained urine. So we have delineated the anatomy well. And then the question is, how do we repair this rectum? And this rectum is so low because the white dot at the bottom is where the anus belongs. We can go in right there and grab the rectum, separate it from the urinary tract, and make an anoplasty.
Got it.
And I like to depict this concept with this diagram. This is a sculpture by Rodin, John the Baptist, in the Musée d'Orsay in Paris. And most people go to the museum to look at the beautiful art. I was on a mission. I wanted to find the perfect elbow to illustrate this educational point. And boy, does that guy have a nice looking elbow, because look what I can do with that elbow. Next picture, next slide. I superimpose the bladder on him, and
So
now I can, what?
1 second. I think I lost. Okay, back here. Sorry.
I superimpose the bladder on the statue. And now, based on where along the urethra, i.e. his arm, the rectum ends, we can define the anatomy. So let's see about that. Next slide. So we could have a rectum to bladder neck fistula, which is represented by a fistula at the shoulder, the deltoid. The yellow one is a rectoprostatic fistula, a little bit lower on the urethra, basically in the tricep area or along the humerus bone. And the green one is the lowest rectum type. It's at the elbow. And back to your original question about low or high rectum, the lower type of rectum is the bulbar, and the higher version of the rectum fistula is the rectal bladder neck fistula. So the rectal bladder neck fistula has less chance of bowel control, more associated problems. The bulbar, better prognosis for bowel control, fewer associated problems based on
Got it.
the rectum and, of course, the associated spine and sacrum.
Got it.
And thank
Very
you.
interesting to use this
Yeah.
figure.
I suspect Rodin was not expecting his statue to have such value to the future generations of medical people, but I found it very useful. And now, because of this, people around the world are defining the anatomy without the same confusion that they used to have. And it's very helpful, because I'd like to know, are we talking about a bulbar fistula? I want to make sure surgeons are having the same conversation about the same anatomy.
Very interesting. So is this did you coin this way of looking at it?
Yes.
Wow.
Yes.
Awesome.
And the title of the paper, which I can't take credit for, one of my trainees came up with this name, is called A Call to Arms. Arms, ARM, Anorectal Malformation.
Wow.
I thought that was very clever.
I think it is very clever. So I think this is very clever to look at a figure and statue, and then use this exact structure as an anatomical structure, and then be able to talk about it in these overlays. I love it.
So let's see if we learned something. Let's go to the next slide.
Okay.
All right. So here we have an obvious fistula from the rectum to the urinary tract. And then the question is, where is this on the idea that there is an arm with an elbow? For me, this looks basically at the elbow. So at the elbow is a bulbar fistula. Okay, let's try another one. All right, the fistula is in the triceps.
Correct. This is the elbow. This is the shoulder. This is the triceps.
And that is therefore a prostatic level fistula. By the way, the parts of the urethra are bulbar, prostatic, and bladder neck. So that's a prostatic. And let's see the last one. And here we're at the deltoid right there, the shoulder. So that's a bladder neck fistula. And when you know this anatomy, you can then decide how to do the surgery.
Love it. Thank you very much for doing this. So is your name then in various books with this model?
Well, I mean, I think the article I wrote will be referenced, but we're going to keep the statue as Rodin. All right, let's see. Now let's take this knowledge. Oh, by the way, this is one very interesting thing I wanted to show you. On the left is the X-ray you obtain that we just showed you. On the right is a new way of doing this with ultrasound. And some radiologists, particularly in Boston, are doing this study without radiation, without ionizing radiation. They are using ultrasound, and they're basically coming up with the same image. This is the same patient. On the left is done with traditional ionizing radiation, and it's a bulbar fistula. On the right, you can see the elbow. Let's see if you can find the elbow. There you go. And the fistula is also in the bulbar. So that's the bladder. Come down, there's the elbow, and there's the fistula, bulbar fistula. Ultrasound, amazing.
Wow. So just a quick thing. When I came to US, the job that I came to do was to work on a 3D ultrasound system because I'm a medical doctor and a software engineer. They wanted two of those people, and they got two of them in one. So I actually worked for a few months. The company was a startup, it went belly up, but I worked for a few months in a company that was creating 3D ultrasound system with virtual uh, volume analysis. Anyways, interesting
Yeah,
technology.
I mean, as you know, the ultrasound technology has improved amazingly well
Yes.
in defining the fetus. The 20-week ultrasound, you can see so much more now. So obviously, this technology is being applied, and it avoids radiation. So it's a really good thing.
Yes.
Okay, let's see. So these uh, and rectums. Where do you find the rectum? On the left one, the rectum is super high. You need laparoscopy to go through the abdomen to find it. On
Is
the
this the
Yep,
rectum?
that's the rectum. Very good. The one on the right, the rectum is much lower and can be found through a posterior incision between the buttock crease. You don't need to go into the abdomen. That's why this imaging is so vital, because it tells you where you're going to find the rectum and what surgery to do.
Got it.
And obviously, laparoscopy is a great modality, but you need to know which case is it appropriate for. So we developed another concept called the PC line, pubococcygeal line. We draw a line from the pubic bone to the coccyx. That's the yellow line. That anatomy is standard. Every baby has a pubic bone and a coccyx. If the rectum is north of the line, you need laparoscopy. If the rectum is below the line, you can go in from the back and find the rectum that way. So this also helps surgeons make a better plan, because they could draw these lines and say, this needs a posterior sagittal approach, or this one needs a laparoscopy.
Beautiful.
All right. And what's next? So I think we should cut here. And for the next session, I would love to go over, after successful surgery, what happens to the patient. Because it's important to recognize you're doing this in the newborn period. You have a little baby. The baby is pooping either through a colostomy, then the anus is reconstructed, and then the colostomy is closed, and now they poop the normal way. Or you did it in the newborn period, you did the anoplasty then, and for the next 3 years, the baby is happy and is pooping into their diaper. So 3 years go by, and now the moment of truth comes. Will that anus work? Will the child successfully potty train? Will the baby now, as a 3-year-old, be able to be in normal underwear? Will they be able to go to nursery school and to kindergarten? All of those questions are now in the mind of the surgeon and the family. Again, we had a good discussion with them about what to expect. But now what happens when they're 3? Are they ready for prime time? Are they ready for continence? The other thing I want to discuss, and this will be in the next session, is what are the things that can go wrong with the surgery? What things might not work well and may need additional revisional surgery? And I'm trying very hard to make the surgeons out there so good that no one ever needs a revised surgery, no redo surgery, and then I will retire with a big smile on my face. But at the moment, many of these patients need some revisional surgery, and we're going to talk through that as well.
Awesome. Thank you very much. I see a couple of questions if I can ask you before we close. Kelly says, is there a connection between anorectal malformations and other malformations occurring within the families?
Yes, I think it's a very good question, and what I can certainly tell you is that the risk of an anorectal malformation in a family and having another family member with another anorectal malformation is a 1 in 200 risk. Whereas in a regular patient with no family connection is 1 in 5,000. And that's Kelly's second question, 1 in 5,000. So 1 in 5,000 is pretty common. 1 in 200 is more common, but it's still pretty rare. So in a family of 2 or 3 or 4 kids, it's very unlikely that you'll have more than one kid. But there is a significant risk to having another baby with the problem, but it's 1 in 200. So still quite small.
Got it. One more question, and probably I'll rephrase it as well. So Mudama Rose says, is it prenatal nutrient related like Spina Bifida? And I had that question as well, that is it just an incidental, accidental genetic issue or malformation issue, or there is some nutrition or
No,
maternal behaviors?
no, not that has ever been identified. There seems to be a small genetic link. For example, Down syndrome patients are more likely to have an anorectal malformation. Obviously, we talked about the familial, but no nutritional or environmental cause has been identified.
Got it. So one final question. This seems to be from a medical student. Sayyid Suhail says, does opting pediatric surgery specialization have good future ahead?
I don't, what do you think they mean by that?
So if I am, let's say in Pakistan, and I'm planning to do surgery and come to US and work, the question in my mind is, how much valuable will I be, and how much of the how would my life look like compared to other doctors? I think that is the kind of question here.
Well, I mean, I think it's wonderful to be a doctor and help people, and you have to apply your skills to whichever type of doctor you choose to be. My personal story is that I loved my pediatrics rotation. I liked taking care of kids. They were a lot of fun and they healed very quickly. But I knew for sure I wanted to be a surgeon. And I vividly remember being upset that I couldn't do both until I learned from a senior medical student that in fact there's a specialty called pediatric surgery, and I could unify my two loves of taking care of kids and performing surgery, and that's why I chose to go into pediatric surgery.
Awesome. That actually answers it. So Sohail says, I mean, in India, pediatric surgeons are overlooked. So Sohail, this may be something that you would have to do your local research about. We may not be able to answer that question here. So once again, Marc, thank you very much. Any closing comments?
No, I really enjoy the format. I have to say, as someone who gives a number of these talks, having someone like you sort of talk me through it and ask questions throughout feels very much like we're just hanging out, sitting on our couch, talking about this subject, which I know is the sort of the comfortable way to learn. And I'm very impressed by that because I feel like it helped me explain things well. And I take a lot of pride in the fact that you learned the anatomy so quickly, and now it's just a matter of teaching you some of the surgical techniques, and you can do this work too.
Thank you very much. I actually, when I started Dr. Bean and these medical lectures and this setup, one of the things I wanted to do differently was I didn't want us to be just presenting some PowerPoints and just regurgitate some information and then people just have to grapple with it. I wanted it to be more clearly understood, explained, recalled, and simplified. And so, thank you very much that you actually present in a way that I, right at the time of presentation, I'm learning and grasping it. So that actually tells about your presentation method as well.
Great. Well, I look forward to our next session, and thank you all who joined.
Thank you. So cool bean, I'll see you at 6 p.m. today. Thank you very much. Bye bye for now.